My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you're interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
My name is Lily Weinstein, and I am a fourth-year undergraduate student at Binghamton University who will be applying to osteopathic school this year, and you are listening to DO or Do Not. Join us as we speak with Dr. Richard Riemer of Touro University, California, who is not only a board-certified neurologist, but the Chief Medical Officer of the Touro University Medical Group. Dr. Riemer discusses the mission of the medical group both to offer superior medical care to the community of Stockton, California, as well as to broaden the educational experience of osteopathic medical students from his college. The group is ever expanding and offers residency opportunities in specialties as broad as family practice, urology, and anesthesia. Dr. Riemer also focuses our discussion on osteopathic recognition and its importance to DO trainees. Join us as Dr. Riemer shares his insights into the field of osteopathic medicine, reflecting on his work in neurology and his experiences as a clinical professor at Touro, California. It's a conversation that goes beyond equal outcomes, aiming for excellence in the educational experience, a sentiment Dr. Riemer passionately believes in. We hope you enjoy this episode.
All right, Dick, thank you so much for joining us tonight.
Oh, it's my pleasure. Thanks so much for having me.
Just a little background, and it's so interesting that there have been a lot of conversations that I've had over the past few weeks regarding medical education, specifically osteopathic medical education, that I think is so pertinent to the conversation we're going to have tonight. One of the comments as a pro and a con, arguably, for osteopathic medical education is that many schools have very varied sites, potentially in different parts of the country where students can go. And again, on a positive, this gives students a lot of opportunity to see different places and rotate through different institutions. As a negative, many MD schools have one central core hospital that they're centered around. So this is an interesting discussion that we're going to look into in future episodes. To further that, I recently had a discussion with Bob Kane, who's we've obviously had on our podcast before and is great. He's a president of ACOM, and he is going to come on and talk to us about social contract with another amazing person that we've had on the podcast in the past, Tanya Jenkins, who is a sociologist and really talks about osteopathic medicine specifically and generally just what physicians owe the community and sort of what osteopathic education does for the community. But all of that having been said, when I interviewed Tammy Hendricks, who is a rock star dean at Touro-California, she said that we have to get you on the podcast to talk about the Touro University Medical Group and all the work that you're doing with the group and tied into the university and the medical school. So can I just wind you up and let you go? And can you tell us about the Touro group?
I certainly can. I joined Touro University as the Senior Associate Dean in January of 2016, hired by then the Dean, Mike Clearfield. And honestly, I had no idea what a Senior Associate Dean was. My prior experience as a neurologist, we can talk about a little bit later, but my motivation for joining Touro University, I was at a crossroads in my own career, having worked at a neuroscience institute and also been affiliated at UC Davis, where I decided that in this latter portion of my career, I wanted to return back to a college of osteopathic medicine and address what I thought were some of the educational deficiencies. And I've been in education for over 30 years, most at the graduate medical education level. And what I had observed over all those years, having many osteopathic medical students from different universities throughout the United States rotate through our neuroscience department and my private practice, was exactly what you said. This was a diaspora of medical students that were sent all over the country or all over their state in order to gain clinical experience. I compared it to my own educational experience as a university trained neurologist, somebody who had that hierarchical structure and organization from attending to chief resident to senior and junior residents and interns and med students. I felt that this truly benefited me as a physician and in training, and didn't quite understand why we couldn't recapitulate that for an osteopathic school. And I was aware that this is not unique to College of Osteopathic Medicine. It's also unique to many allopathic medical schools. And I don't know what that percentage is, but it's considerable, where there are not university hospitals or large hospital systems. And so what you have are medical schools competing with each other in order to identify teaching hospitals to send their students there for these types of experiences. And I was motivated to join Touro because I wanted to see if I could have some effect on that, whether I could come up with an organizational scheme and a strategic plan that would help organize student rotations in such a way that the medical school had control of the clinical learning environment, had a way of presenting its curriculum and ensuring that the student experience was excellent. And that if I could do this at the same time of minimizing the amount of travel and locking these students into rotation sites that were intimately connected to the medical school and to the faculty, this would augment their educational experience. So the opportunity came up into my very early in my first year as we were trying to identify medical centers that could sponsor both undergraduate and graduate medical education. And I was introduced by my predecessor, Dr. Greg Lund, who was the Senior Associate Dean at Touro, who had made connections here at St. Joseph's Medical Center. And it really was a perfect storm because at the time that I came and Greg was leaving, the leadership at St. Joseph's Medical Center was exploring the development of ACGME residency programs. This was also catalyzed by one of our students' mothers who sat on the board at St. Joseph's Medical Center. And by way of background, St. Joe's is here in Stockton, California. We're 70 miles inland from the Bay. We are in northern San Joaquin County. This is a health provider shortage area with a medically underserved population. Sometimes the Central Valley and San Joaquin Valley and County are known as California's third world country. The ratio of physicians to patients and the demographic is such that it's extraordinarily diverse. We're the breadbasket of America with a large migrant immigrant population and one of the most, if not the most diverse population in the United States. California always ranks with 7 cities out of 10 being the most diverse, and Stockton and Sacramento generally vie in the top 3 for that. So with that in mind, this mother of one of the students came to Greg Lund and said, why is it my daughter can't do a rotation in Stockton, a 355-bed acute care hospital with 35-bed freestanding psychiatric facility? Why are there no medical students being educated here? It was at that point that I joined the university and established relationships with leadership here and their team. And we all explored opening up residency programs, and that Touro University, California, would become the home institution, the primary medical school affiliate of what are now 9 ACGME accredited programs. And we just had 2 fellowships approved as well, and a 3rd pending. And so what would occur is that 9 residencies are now standing. And with Touro now as the home institution, it became clear to me in the very beginning of this that for this to succeed and to move away from the model of outcompeting Caribbean schools, international schools, other medical schools in the state, it would be best if we could fill the educational gap by establishing our own medical group that lives or works in the area of Stockton. We are all on faculty at the hospital. We're opening up medical service lines that never existed before. And so we're faculty at the university, we're the faculty in the GME program, and this is priceless because we are now in leadership roles at the GME level for the hospital. We're integral to the educational process in all 9 residencies. We are the faculty, we are the educators, we are the scholars, and we're bringing the experience of Touro University and we're leveraging that educational experience to influence a clinical learning environment where we as faculty at Touro control that. and have medical students and residents rotating through our different specialties. And so that, in essence, is what we've done. By doing this, we now have 49 to 50 medical students all doing their third year core rotations. These core rotations have to be the same for all medical schools in California in terms of the specialties and the duration of these rotations. So they're all doing that here in St. Joe's and in Stockton. And of course, our students are now exposed to that organizational structure, which I was talking about earlier, that you would find at a teaching medical center.
Sounds spectacular. Sounds very, very cool. We have a student who's part of our podcast who your university was gracious enough to accept. He's going to be a great addition to your school. But I think that's one of the big selling points for the school was the university program and exactly what you're speaking about.
Yeah, I think others have said this to me, and I'm not espousing this, that this may be a model. I know that some folks have taken a look at what we're doing here, which is the ability to develop a medical group and embed ourselves so that, as I mentioned earlier, we become integral to the care of the community. So we're solving many issues. Number one, we're introducing specialties that either didn't exist or were poorly represented in the area. We're bringing in academic faculty to run these programs. We're growing medical service lines that heretofore didn't exist. Care for an underserved population is now occurring. We're enhancing access to care. We're providing services again that oftentimes you don't see unless you're sent out of town to Stanford, UCSF, or UC Davis, or some of the other large systems like Sutter and Dignity Health. And so we're now able to provide a lot of these services locally. So everything from neurologic robotic surgeries to use of immunologic and biologic agent for neuroimmunologic diseases to neurocritical care to epilepsy therapies to continued growth of all of these specialties in rheumatology and infectious disease. This is all us. We are now growing adult and child psychiatry. We have inpatient services, neurohospitalist service, neurologic admitting services, urologic in-house, surgical centers. We're just continuing to expand and grow. We're not huge. Don't want that. All of that menu sounds like we've grown a huge medical group. We're not. We'll probably be at the end of this year about 20 physicians. And many of us are DOs and oriented towards osteopathic medicine and philosophy, which is important to us as we, of course, affiliate. And I know you had interviewed two of my favorite people, which includes a close friend and colleagues, Alan Yee and Tammy Hendricks. And I share a very similar philosophy with Alan, both of us being neurologists and seeing the value of OMM in our practices.
So I guess my first question is, can you tell us what those 9, and I don't expect you to rattle them off, although if you can, I'd be very impressed. Can you tell us what those 9 residency programs are?
Yeah, we've got residencies in emergency medicine, year, family medicine, psychiatry, neurology, urologic surgery, orthopedics, and psychiatry or anesthesiology. Those are the 9.
That was very impressive. I have 2
Yeah.
kids. I can't rattle off their names. Okay, so a student comes to Touro and they have this great opportunity. What percentage of students are rotating in the group? And then if a student comes to Touro, California, with the intent of rotating in the group, is there any chance they wouldn't get those rotations because there are limited spots? I don't know the number of students that are accepted each year.
We just had a class size increase to about 180. Previously, we were 135 and we're offering 50 spots. So it wasn't more than a third of the students were rotating here. Obviously, the percentage has changed right now. The hospital is growing and service lines are growing. And I actually anticipate that number will go up in a number of years. The medical center here plans of growing to nearly a 550 bed hospital sometime in the next 4 to 6 years. And which just means more opportunities for learners and continued growth for the school.
You mentioned 20 physicians that are directly involved. Are those employed physicians by the group or the private practice doctors? Are there ancillary doctors on top of that number?
Most of the physicians are employees, and we do have a couple that are independent contractors, but they're contracts exclusively with the university. We're unusual in California, similar to Texas, where corporations are not allowed to hire physicians. There are carve-outs for that, like the University of California or rehab hospitals or the Department of Corrections. You generally have to form what's called a medical corporation, which hires physicians and then contracts with a foundation, a non-for-profit. That's the model we have. Touro University Medical Group is a 501c3 non-for-profit, wholly owned subsidiary of Touro University, California, which of course is part of the larger Touro University system. We have a group called Touro University Medical Associates, which hires the physicians, and we practice exclusively through the auspices of the nonprofit. There are lots of benefits to this. It's a California model. It really looks no different if you were Kaiser Permanente in California. It's the same organizational structure as defined by the California Corporate Code and Business and Professions Code. And this is how we have formed this.
And Dick, my last question on the group, it really sounds like an amazing project. It really sounds great. Two-part question, kind of similar, but split. A lot of students, you would hope that are training at Touro are going to stay for the residencies. So I guess my first question is, for things like family practice or internal medicine or neurology, do you find that the students that are at Touro are questing or trying to get those spots? And as a follow-up question, a lot of students are interested in competitive specialties such as urology and orthopedics that are very difficult. Do you find that obviously those spots are going to want to take the best candidates, but those people from Touro are known? Are you finding that that's giving them an advantage for those spots being from Touro?
I do believe that's the case. You're aware that we have a very good placement for residency matching, and last year's class, 11% of the graduates matched here at St. Joe's, which is really impressive. And because we are the primary medical school affiliate, our students have first choice for all sub-Is. There are other medical schools and medical students that rotate here, but our school has preference. And so this gives our students a leg up, if you will, an opportunity to expose themselves and hopefully succeed, become indoctrinated in the system and do well. So we have many Touro students that place into residencies.
Amazing. Again, sounds really, really amazing. Dick, we're gonna shift gears. Thank you so much for sharing that with us. Can you tell us where you grew up and when you decided you wanted to be a doctor, and maybe where you went to college?
Yeah, absolutely. I grew up not too far from where you're sitting. I grew up actually, parents from the Bronx and Queens, and grew up in New Rochelle, New York, and went to undergraduate school at the University of Rhode Island, and was thinking about medicine throughout that time, and thinking both about allopathic, and was introduced to osteopathic medicine, which I had heard of but didn't know too much about, by, I would have called him a mentor at the time, and that was Dr. Lawrence Bouchard. Dr. Bouchard practiced in Narragansett, Rhode Island in the South County, and would go on to become the president of the AOA in 1993. And Dr. Bouchard would come and talk to the pre-medical students. And I wondered who this fantastic doctor was who was practicing family medicine in this small town in this coastal region of Rhode Island. I was just so impressed with him, and he and I formed a relationship. He was one of the founders of the New England College of Osteopathic Medicine, and actually encouraged me to apply to osteopathic medical schools, which I ultimately did, and then attended at Kirksville College of Osteopathic Medicine, where I graduated in 1984. But it was Dr. Bouchard pretty much that had influenced me to take a look. I'll never remember many of the things that he said to me came true. He said, we're a wonderful profession. We relate well to patients. We're an important part of the healthcare system, and we're small. And because we're small, there's these opportunities to do things with a little less competition that make a large impact, an outsized impact on the community and in the United States than you would normally anticipate as a physician if you were part of a much larger system. And I can reflect on this a little bit more, but Dr. Bouchard was completely correct, because my trajectory in my career ultimately led to things that I'm doing now, where I have this opportunity to develop graduate medical education as a senior associate dean affiliated with Touro University. It also led to many years of working with the osteopathic physicians and surgeons, where I ultimately was president of that organization for the State Medical Society. So a lot of what he predicted in my career came true with these opportunities to have an outsized impact as an osteopathic physician. And that impact can't be diminished by anybody. Of course, if you've ever been to the AOA House of Delegates, or you've worked in these state organizations, or you've lobbied for bills, and you've testified at Senate subcommittees, we have a seat at the table. And that's something else that I'm rather proud of, is all of the work, 10 or more years, that went into representing osteopathic physicians of the state, and the impact that we've had on the House of Medicine here in California, which of course has, as they often say, a trickle-down effect across the country.
Dick, so you start in New York, then you're in Rhode Island, then you're going all the way across to the mothership. You're going to Kirksville for med school. How
Yeah,
did you decide on neurology? And can you tell us a little bit about your application into residency?
I'm happy to do that. I always had an interest in neuroscience, and even as an undergraduate. So while I was a biology and genetics major, I took a lot of neuroscience classes and absolutely loved them. I was like a lot of doctors, I think. I had a subscription to Scientific American. And in 1978, there was a publication on the brain with authors, some of which were Nobel Prize, I believe, laureates. And it just absolutely captured me. So as I was in medical school, I just loved the neurosciences. But I graduated at a time when there were still small osteopathic hospitals in 1979. And so I decided to attend my internship year at Tucson General Hospital. And that was a classic rotating internship, osteopathic internship in Tucson at that hospital. If there were deficiencies in our education, I had the benefit of being at the University of Arizona. So that was my exposure to a large university. And when I was thinking about what I wanted to do, I had another great mentor, Dr. Tom Vigorito, who had actually been the dean at some point of Des Moines College of Osteopathic Medicine. He was practicing neurology in Tucson. And I just fell in love with neuroscience even more, and decided that I would apply to neurologic residencies. And decided also, after a long day shift in general surgery, I was living on the West Coast in Tucson. My wife and I were lounging by the pool. We were looking at the mountains and the desert sunset, and I said, perhaps we want to stay west. We can always move back to New York after residency and fellowship, but I'm enjoying this, and why don't we stay in the West Coast? So while I applied to residencies throughout the country, not many, I applied to UC Davis as well, and was accepted at Davis, other places as well, but I decided to go to Davis. And I was I'm told, the first DO ever to have attended UC Davis. And I believe there was a fellow in gastroenterology and I that joined it the same year, but I was the first resident. And that was sort of cutting edge, and had a great experience there where I finished fellowship. And that was the story of my training.
Dick, can I ask you, I guess, two questions on UC Davis? So, of course, we interviewed Alan Yee, and we talked a lot about sort of prestigious institutions, and UC Davis is certainly, for those of our listeners that don't know, a very impressive institution. How did you feel as a DO in that institution? And now, remembering this is a while back when DOs were maybe not as well known as they are now. So how did you feel as a DO there? How were you received as a DO there? How was your application process? And you feel being at that institution?
Well, it's really a great question. And I often tell this to the medical students. I feel like that individual standing at a dock with one foot in the rowboat and the other on the dock, straddling two worlds, really. And as the metaphor goes, there's not a solid foundation, and there wasn't a lot of, I guess you could say, examples and mentors that would help you navigate that. And so for me, I will tell you that my application at Davis, while it was accepted, the interview process was interesting because not everybody wanted a DO resident. I think I had more hubris and confidence then, probably more than I have now, but after almost 40 years in practice. But it was interesting to accept that position, knowing that there were people in the department that weren't quite sure that an osteopathic physician had equivalent training. And I felt a lot of pressure to prove myself. I worked extraordinarily hard and made sure that I was doing as best a job as I could. And I think that that's just my work ethic. It obviously paid off and was well thought of in the institution. My first year there, I can tell you I had experiences that included pharmacists calling me, wondering if I had a license to prescribe, didn't know what a DO was. And I was on an educational mission to demonstrate that my education was equivalent on par, and in some areas, I'd like to say better than some of the experiences of my allopathic colleagues. And I had never, ever lost my osteopathic perspective. It has always been an advantage for me in the field of neurology, even as I was a member of an affiliate at UC Davis and in other private groups with other allopathic trained physicians. I had a observational and skill set that they did not. And our training really allowed me to take advantage of that.
Can you tell us a little bit? First of all, did you do fellowship?
Last year was fellowship in clinical neurophysiology, and I grandfathered into neurorehabilitation as well. And so that was my postgraduate training.
I hate to show my naivete, but can you tell us what that fellowship is?
Yeah, it exists today. That's training in reading EEGs and electromyography or EMG and nerve conduction studies and what's called evoked potential training, intraoperative and outpatient evoked potentials. So these are the electrophysiologic tests that are part of the repertoire of testing that we do as neurologists to diagnose a whole variety of diseases. And it complements understanding diseases from Guillain-Barré to muscle diseases to myasthenia gravis and so forth, or maybe it's just as simple as carpal tunnel syndrome.
Very cool. Okay, so then you're looking for a job. It sounds like you already decided you're going to stay on the West Coast. Can you tell us a little bit about what it was like looking for a job and then give us a little map through where you were from there to here?
I ended up joining a neurologic group in the city of Sacramento. I did look at various areas back in New York and suburbs like Tampa. That's a joke. I know my mother will probably listen to this, but to the disappointment of my parents, I stayed on the West Coast because I had a good job offer. And after several years, I became an associate director of a spine care center while I was still practicing neurology inpatient and outpatient. And that was a formative 5 or 6 years of my early vocation. And continued to practice both in private practice and then remained affiliated as a very active adjunct at UC Davis for over 30 years, where I was part of committees and did research and staffed the residency continuity clinic. That all leading up to ultimately my work with the Southern Neuroscience Institute, where I was the director of another spine institute. And when I say that, it's not just back pain. These are patients with autoimmune diseases and spinal cord tumors and congenital abnormalities and multiple sclerosis and transverse myelitis, all the diseases that affect the peripheral nervous system and spinal cord. And did that for a while with Sutter. And then the opportunity came up to go back to a COM. Actually, the opportunity was to do that or head back to Davis full time. And I just thought I might have a larger impact at Touro. And that's what led to where I am today.
That is an amazing career and obviously still going. But I have a couple of questions, things that you mentioned that I really want to delve into a little more. Can you tell us a little bit about your work with the Osteopathic Physician and Surgeons of California, advocacy, how you got interested in that? Did that parallel your practice? Talk to us a little bit about that work.
It always parallels your practice. And for anybody that's involved in advocacy or volunteer work for their state organizations, every DO listening to this understands that's extracurricular. You're not eating dinner with your family. You're on meetings and calls. Really, the osteopathic profession here in California has blossomed over the last 30 years. There were not many of us. And if you know the history in California back in the 1960s, the amalgamation of the osteopathic and allopathic profession occurred at that time, where DOs lost their terminal degree and became MDs, and with I think it was a $15 conversion fee, ended up with they didn't necessarily practice as allopathic physicians, but the DO degree was eliminated, as well as the board. And it was in the 1970s when this was reversed. That had a huge impact on the number of osteopathic physicians in the state. But fast forwarding, by the time I was done, there weren't that many of us. And so it was clear to me from establishing relationships with other DOs, we all just shared this cultural thread and this common education. No matter that I was also allopathically trained, I felt a kinship, of course, with my osteopathic brethren. We saw the world just a little bit differently. I often say people would ask me, what's the difference between an allopathic doctor and an osteopathic doctor? And one of the analogies I use is I say we're both part of the house of medicine. But we live in the living room and they live in the upstairs bedroom, and we see the patient on the front lawn, but we have a different perspective. And so we're all living in the same house, but we approach that patient a little bit differently. And I can then go into why that is. So I ended up really, because there were so few of us, I felt it was almost, again, part of my obligation to give back to the profession and to represent osteopathic physicians in the state. At the time, just like I early on had explained some of the challenges I had as a DO in an allopathic institution very early on, I thought it was most important that I address any disparities and discrepancies and prejudice against us. And that led to me becoming more and more involved. I was very involved over the course of probably 10 years. I led the legislative committee as chair for at least 3 years, was on that for many more years. I think ultimately I was on every possible committee at OPSC and made the decision to head into the leadership ranks from secretary and treasurer to vice president, president-elect, and then president and immediate post-president. And it too was just a very interesting journey. We dealt with a lot of bills and legislation that had a direct impact on both patient care, on reimbursement for osteopathic medical therapies, on scope of practice, and even the prejudice that unfortunately still exists to some degree even today, but it's really minimal compared to what we were fighting years ago to make sure that our students had equal access to rotations and job opportunities.
Do you think that those experiences opened the doors for what you're doing now, or was that completely separate?
I think it's all interconnected. All of these experiences contribute to who you are as a person and your perspective. I'm of course, the chief medical officer and executive of the Touro University Medical Group. And it wasn't my initial goal to be the residency director, the program director for the neurology residency, but I am. And so I now have 8 residents, a total of 4 per year, so we'll be 16. And all of this influences my educational perspective and even the curriculum. And we are a community-based program at a growing teaching medical center. And our focus is on community, on advocacy, on outreach, on pipelines, on reaching back into an underserved population. We hope to be able to exemplify or be the exemplars of pathways for underrepresented populations to enter into healthcare and medicine. All of these prior experiences are influencing what I'm doing today.
Amazing. Amazing. And Dick, my last question, just tying back into Alan Yee, who obviously is a spectacular paradigm, as are you, of an osteopathic specialist. As far as manipulation, and I know you commented your positive feelings towards osteopathic manipulation, certainly primary care specialties and OMM have a great interconnection. I feel like sometimes for specialists, it's either the specialist is an osteopathic specialist specifically, or a specialist in their own medical subspecialty. And then through the podcast, we've come across a number of DOs that I fondly term hybrid DOs that have found a way to integrate OMM into their specialty practice. So is that what your practice has been like? And can you talk to us a little bit about that?
Yeah, we might need another 3-hour podcast for me to talk about this. I'm quite passionate about it. I don't know if I'm a hybrid. Maybe I am, but hybrid sort of suggests that the right half of my body's a DO and the left half isn't. But either way, I think that the transformation to being a doctor has always fascinated me for years. from watching a medical student enter into a residency. And for me, neurology, 4 years later, they're walking and talking and sounding like a neurologist. And I always think, how does that happen? And it does. This transformation occurs. And the reason I bring that up is that that transformation occurs through the filter, if you will, of your education in medical school. And so if you went to a place like Kirksville, you can't separate out the osteopathic philosophy and approach towards patient care. It is imbued in you, whether you want it to be or not. It literally, you have been inoculated with a virus that's changed your DNA, and you express this perspective regardless of how much you want to or don't want to. It's just your approach. And so for me, I did not specifically focus to say, today I'm going to treat 3 patients osteopathically. Today I'm going to look through osteopathic eyes. It happens naturally. And the best way I can explain this to you are examples. And I know Alan on the podcast talked a little bit this in reference to his treatment of stroke patients. But when I evaluate somebody, I'm still old-fashioned. I put my hands on them. I do a structural exam, because if you come in with back pain to me and you're my patient who has had a spinal cord lesion, I evaluate you like every other neurologist. But what I might do differently is that my palpatory skills and my observational skills can isolate somatic dysfunction and can isolate muscle groups that are not working normally because of a spinal cord injury. And I can design an osteopathic approach combined with therapy that improves that. And many times these problems go away. I had a patient literally 2 days ago with MS that predominantly affected her cervical spine. Her complaint was right lumbar pain. It was non-radicular and non-radiating. We watched her walk. We identified weakness of particular muscle groups. We identified spasticity of paralumbar muscles. That was now due to an aging spine with scoliosis. And secondary to that was the spasticity arising asymmetrically from her asymmetric spinal cord lesion related to her MS. The allopathic resident with me said, maybe we should treat her with an antispasmodic. And I said, maybe we should, but let's evaluate her and let's see if we can actually improve this right now. And after evaluating her, identifying her structural abnormalities, and then applying techniques, including soft tissue and muscle energy, the spasm went away. You could palpate it and you could see it. And the patient said to you, I haven't been pain-free in 3 years. What did you do? This is the impact of osteopathic care as a neurologist. Now, she needs to come back, and I've set up a program for exercise and for stretching and palliative types of treatment and working with the therapist. But it's this type of approach that we have, which is just different. My evaluation of that patient, my ability to diagnose the problem is no different than any other neurologist in the world. But my approach to her treatment was different, and it required an osteopathic perspective in order to actually identify the root cause, which was complicated, and address it. So I think these examples give a much better idea as to how I practice as an osteopathic physician and what the benefit is as a specialist.
I think that's an awesome example of look at the patient as a whole, right? I talk about that all the time. We talk about these catchphrases, but sometimes it's really hard to understand, especially when I speak to MDs or MDs are talking about osteopathic medicine, for them to understand. And I think if they listen to that about 5 times, it'll kind of make sense.
There's just so many examples for the patients we see, from Parkinson's disease to stroke, et cetera, that if you were to focus on the whole patient and had this skill set, you make a lot of people better.
Dick, thank you so much for all of your time. This has been an amazing conversation. I have our last grand finale question for you,
Yes.
which is, can you give us one piece of advice, and if that you've been given from someone else throughout your journey that has been impactful to you, that you think would be helpful to our listeners and you would like to pass on?
I certainly have had lots of advice throughout the years and lots of mentorship. More recently, I will tell you that something that I think is important, particularly for our young listeners who are in medical school or aspiring to that, or even right now wondering what they want to do in residency, is to first identify your values. What's important to you? Those two or three core values that maybe you have never took a moment to sit and think about, and let those values guide your goals. Because if you live a life that's based on your values, you naturally migrate towards goals that are compatible with that and a happier life and something that's fulfilling. And oftentimes it's those values that identify why it is that you're doing things. It reduces your burnout. It refreshes you each day. And you can, in the end of a career or maybe the end of a workday, reflect on the fact that you were living those values and it was worthwhile to yourself and in turn worthwhile to others.
That's great advice, Dick. I very much appreciate it. And I really appreciate your time. We appreciate your effort in osteopathic education. And again, thank you for spending time with us tonight.
Thank you. It was a pleasure. Thanks so much for the invite.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.